along the way, I'll impose upon you my hobby, which is underwater photography, and such as this eagle ray, who, as you see, is very happy to see you all. No financial disclosures in case any of you are starting to develop a bilateral ptosis. As we continue, this shark will come out and bite you. So everyone, stay away for the next slides. Before I get into the meat of the topic, I want to announce to all of you a wonderful thing that's going to be happening in 2016. APOS, the American Association of Pediatric Ophthalmologists, is sponsoring now co-sponsoring now international meetings. And our third one in the world, in the history of APOS, was going to occur in December in Jaipur, 2016, in conjunction with the Strabismus and Pediatric Ophthalmological Society of India. We encourage all of you to come, and I can't help when speaking about international efforts without acknowledging Dr. Marilyn Miller, who's in the audience. She has been the spearhead for more than 20 years of international efforts from the U.S. to other countries, India, Nigeria, and many other places. And also Dr. Del Monte, who was the head of the International Committee of Naples for many years, and helped us also go international. So please be aware of those dates, and hope to see you there. We're going to talk about neonatal conjunctivitis now. Well, what's the definition of neonatal in this context? It's an ocular inflammation arising within 30 postnatal days. It reportedly occurs between 0.3 and 16% of births, depending on what country or region you're talking about. It may be infectious, it may not be infectious. What are the causes? The most feared cause is Neisseria gonorrhea. In the 19th century, this is hard to believe, this is documented. In the 19th century, gonorrhea was the #1 cause in the world of blindness in babies. The #1 cause was gonorrhea. Something's loose. In many places, such as well documented in Germany, Denmark, it was as high as 10% of all babies developed gonorrheal conjunctivitis. In the early 20th century, in many countries, it was documented to cause 20% of all children in schools for the blind. Now it was much less, but still without prophylaxis, the incidence is as high as 23% in Kenya and other places. How is it acquired? Obviously, it's acquired from the birth canal with a transmission risk of about 17% if the mother has it. However, it also occurs from ascending infection from amnionitis and, as we've seen, unfortunately, a number of times, contaminated secretions from an adult hand. The onset is fast. The onset is between day 1 and 21 of life. The discharge arises sometimes a little later. If it's after a week and you suspect this, consider that it's acquired after birth. This will present with the most marked inflammation you have ever seen, and you will have in an eye. There's severe eyelid swelling. There's chemosis so bad that the conjunctiva balloons out and beyond the eyelid margins in the worst cases. Copious virulent discharge, and the cornea can penetrate with a necrosis with potential opposite scarring and blindness. It's bilateral in roughly half the cases. And my picture is not coming up. See, there we go. Now, when I tell you copious discharge, this is copious discharge. When you see a child like this, you better wear some glasses or back off. Years ago at UCLA, we actually had a resident examine a baby like this, get his eye really close to examine the baby, pull the eyelids apart, squirt, and he'd later develop gonorrheal conjunctivitis right into his own eye. So there's a lot of pressure, so be careful when you examine these babies. And the worst cases like this can result in a perforated cornea. The second most concerned cause is chlamydia. This arises in 10% to 43% of cases. Why is it bad? Because cervicitis chlamydia is found in 2 to 18% of women. Of neonates exposed to chlamydia, 28% to 70% become infected. If a child has chlamydial neonatal disease, it most commonly occurs in the conjunctiva and then other areas. presents in a less severe fashion than gonococccus with milder swelling, but it's more chronic. Ecchymosis is found with hyperemia, papillary reaction, pseudomembranes in the most severe cases, but that takes weeks and weeks to develop. Peripheral scarring can also occur over time. And here's such a patient showing the conjunctival reaction, and you can see a little bit of the pseudomembrane there. It's usually unilateral. It arises later than gonorrhea at about a week. But after 6 weeks, it's considered something else. If it's left untreated, it's self-limiting in some cases, but after 6 weeks, older infants will display polycystic conjunctivitis. Younger infants are incapable of developing follicles and they won't show. The thing that we don't worry about, but the pediatrician does worry about, is pneumonia. They tell me that no baby ever died from chlamydia conjunctivitis. Babies have died from chlamydia pneumonitis. And if the baby has it from birth, there's a 10 to 20% incidence of pneumonitis. Sometimes with conjunctivitis, often not. So if you diagnose chlamydia conjunctivitis, you should notify the pediatrician that that's the case. And that's the reason why when it's treated, I'll get into treatment in a second, you have to use systemic medication because of pneumonia, not because of conjunctivitis. Other causes are viral, such as herpes, with eyelid swelling, congestion, corneal puffing. This you're familiar with. Other viruses are quite rare. And here's the case of a baby with herpes conjunctivitis. Just viral conjunctivitis. When the baby has viral conjunctivitis, herpes conjunctivitis, often the child is very ill with a systemic herpes disease and will be on ganciclovir or some other disorder. Other causes are various types of bacteria. You see listed here, both gram-positive and gram-negative. If the baby has a gram-negative bacteria in the eye, often they can have sepsis. That's a big concern. Chemical conjunctivitis is something you have to rule out. It can be caused by any of the prophylactic agents, up to 50% of cases in some studies, depending on how you define inflammation. After 24 hours, it's down to 7% or less of babies that have it. In the old days, silver nitrate was a culprit. Silver nitrate would cause it. Today, silver nitrate, to my knowledge, is no longer manufactured anywhere in the world for ophthalmic use. There was one factory in Germany that was still manufacturing it about 10 years ago, and that been told to discontinue. So you won't see silver nitrate for the eye anymore. Prophylaxis, an interesting story that I'm going to try to summarize in 2 or 3 minutes. Prophylaxis began in 1880. A doctor named Day in Germany discovered that he applied silver nitrate 2%, later reduced to 1%. He decreased the incidence of gonococcal conjunctivitis in his hospital from 10% of all babies born to 0.3%. This was a milestone in preventive medicine, one of the first great milestones for preventing disease ever in history, and it was done in ophthalmology. Silver nitrate was frequently caused chemical conjunctivitis, less effective against chlamydia than other medications. As I said, it's no longer manufactured. Some places used to use tetracycline, but it's questionable against chlamydia, and often does not work against gonococccus because of resistance to it. Tetracycline is seldom used anywhere in the world. Erythromycin is commonly used today, especially in the U.S. It is effective against chlamydia in most cases, but then there are some cases where there's some question based on studies in Louisiana and Seattle, Washington. And it's widely used in Western countries. Povidone iodine that we published about in 1995, as you see at the bottom, today is possibly the most commonly used iodine in the world for this right now. We proved in a study in California and later in Kenya that it was as good or better than any of the other agents, meaning the erythromycin or silver nitrate. It causes less chemical conjunctivitis. It is way cheaper than these other medications, and therefore it's being used worldwide. Curiously, it is not used in the United States. Since when I appeared before the Food and Drug Administration, they demanded a U.S. trial. The U.S. trial would cost about $2 million US, and no one's going to spend $2 million US on an eye drop that costs about 1 or 2 US pennies per drop. There's no profit in it. Nobody's willing to pay for it. So the irony is, even though American studies developed this thing, we nerve. But it's being used all over the world, which is fun. We also thought perhaps the second ultrasound would help. After the first got 24 hours, we would see even a better decrease in bacteria. Anyway, the study that was published in the British Journal, we found that the second eye drop really didn't benefit. So the one eye drop was fine. This recent study, such as this one in Iran, showed that erythromycin ointment versus saline versus nothing. You see the conjunctivitis rate, there's no difference. But another study in Iran from the same year, from a different group, showed that the potent iodine gave the best results at the lowest incidence of infections. Canada and a Canadian study of a meta-analysis study of 8 different studies that showed that against gonocockus, all these drugs were able to be effective. Against chlamydia, erythromycin and potent iodine are more effective. This is lost. So, what do you do when you have a baby who comes to you that you made the diagnosis of conjunctivitis? You want to get a history from both parents. You may have to ask them separately. Often one parent will not admit before the other parent can give you the proper history. You want to ask about urethral or vaginal discharges. You want to ask about any genital vesicles, sexually transmitted diseases, and compliance with prenatal care. This instance, the disease is far higher in women without prenatal care than with. Regarding the child, you want to ask the onset of symptoms and signs. Laboratory-wise, what do you need to do? You need to scrape down the child, really scrape, not just a swab, but take a caloric spatula or some other spatula and scrape to get exudated cells, ram-stain it, looking for gonocockus, looking for other bacteria. You want to do immune sustain for cytological changes, looking for chlamydia, and then you want to do a direct fluorescence antibody analysis or ELISA testing for chlamydia. Depending on your site, you may want to culture using blood agar, chalk agar is like with raw. And then there's also, this is not used very much anymore, but there's tissue cultures available for chlamydia. No, I didn't have this one. What's the treatment? For gonorrheal conjunctivitis, amazingly the treatment is one IM injection or one IV infusion of ceftriaxone. If you give it IV, you give it once or twice IM, they'll give it daily for 7 days. But there's been studies showing that just one IM injection alone is often effective against this horrendous looking infection. If you're going to do that, though, you want to use something topical, that says at the bottom here, to prevent membranes and adhesions. So saline solution would be fine, irrigate. Some people use bacitracin solution, irrigate. One of those would be good. The alternative would be ceftriaxone IM if you don't have ceftriaxone. If you remember, we talked about pneumonia in the context of chlamydia. That's why we need to use oral drugs and not just topical. So we generally use oral erythromycin syrup, and we'll consider something topical in addition, such as sulfacetamide and tetracycline. If it's non-gonococcal and it's not chlamydia, pretty much any broad spectrum ophthalmic ointment would be fine, and sulfa's fine, erythromycin's fine, Neosporin ophthalmic ointment is fine, and any of these will work. For herpes, you need ancestral, but often this is in the context of a systemic problem, and the pediatrician will treat it anyway systemic. So, that brings us to the close of this, and I just want to let you know that when I was in Indonesia diving last year, and I saw this very friendly Remora eel, and he and I started chatting underwater, and I told him that I was coming to Agra to speak to this wonderful Indian audience, and not only was I excited, but he got excited too. Thank you so much for your attention.